All right, pathology trainees, let's talk about something that can be a real headache, the major salivary gland resection report. If you've ever stressed about getting it perfect, well, you're in the right place. Today, we're going to decode the CAP protocol you absolutely have to know. So let's jump right in.
So, first up, why do we even care so much about this? I mean, it's just a report, right? Well, no. The CAP protocol, it's not just some checklist you tick off. It is the gold standard, period. Think about it. It makes sure that a pathologist in one city is reporting the exact same crucial info as a pathologist across the country. That standardization, it's the absolute foundation for quality cancer reporting. It means consistency, which leads directly to better patient care, and, it's what fuels the research that moves us forward.
Okay, so here's our game plan. We're going to walk through this just like you would in the lab. We'll start with scope, move to the specimen, then histology, margins, lymph nodes, and wrap it all up with the final synoptic report. Let's get to it.
All right, section 1, and this is so important. Before you even start, you've got to know, when does this protocol actually apply? Seriously, grabbing the wrong one or using it when you shouldn't, that's a recipe for some major reporting errors. So let's draw some clear lines in the sand.
Okay, look at this. The lines are pretty black and white, right? This protocol is for resections. We're talking about your peritidectomies, your submandibular gland resections, that kind of thing. What it's not for, biopsies or cytology. Nope. And for tumor types, we're zeroing in on primary carcinomas and neuroendocrine carcinomas in the major salivary glands. Sarcomas, lymphomas, tumors from the minor glands, they all have their own set of rules. Honestly, just getting this part right from the get-go is half the battle won.
Okay, let's move on. Imagine this. The specimen hits your grossing bench. This is it. This is where the story of this cancer really starts to take shape. And believe me, the details you're about to document, they are the foundation for the entire pathologic stage. But before we even think about inking and cutting, let's just do a quick anatomy refresh. We're talking about the big 3, right? The parotid gland, that big one right by the ear, the submandibular, tucked under the jaw, and the sublingual, right under the tongue. You've got to have this map in your head to really nail the tumor's location and how far it's spread. So what are the absolute must-haves for your gross report? The things you cannot forget? Well, you've got to list the procedure, the exact site and which side it's on, and of course the tumor size in centimeters. But here's a big one. You have to describe any macroscopic invasion. That means anything you can see with your own eyes. Is it digging into soft tissue, the skin, a nerve? That single observation can be the difference maker, instantly bumping a tumor up to at least a PT3.
All right, we've grossed it in. Now let's follow the tissue and head over to the microscope. This is where we get into the real nitty-gritty, tackling 2 of the most critical jobs, figuring out the exact histologic type and giving it a grade.
Salivary gland pathology is notorious for its zoo of different tumor types. I mean, this list here is just the tip of the iceberg. And getting the histologic type right, it's everything. It is the absolute cornerstone of the diagnosis. It's the #1 thing that's going to predict how that tumor will behave and what the patient's future looks like.
And this table just proves the point, right? Not all salivary gland cancers are the same, not even close. What's cool about the CAP protocol is that it dumps the idea of a one-size-fits-all grading system. Instead, the grade is often built right into the diagnosis itself. A low-grade mucoepidermoid carcinoma is a completely different beast than a high-grade one. And then you have salivary duct carcinoma, which is basically high-grade from the moment you diagnose it. The key takeaway here, classification and grade are totally linked. Okay, so we've identified our bad guy. We know what it is. Now we need to figure out, where is it going? What's its plan? This is where we look at surgical margins and how it's invading. And this is mission critical for figuring out the odds of it coming back and whether the patient needs more treatment. And one of the first things you should be hunting for is perineural invasion, PNI. This is when the cancer cells literally use nerves like highways to spread. It's a classic sign of aggressive behavior, especially in tumors like adenoid cystic carcinoma. And let me tell you, there's a very, very good reason it's a required part of your report.
So why all the fuss? Why does this matter? Because every single one of these findings directly changes what happens to the patient. You find positive margins? That could mean another trip to the OR. You spot PNI? That's linked to worse survival and is a huge reason to give the patient radiation. And LVI, or lymphatic/vascular invasion? That's a giant red flag that the tumor is trying to escape to the lymph nodes and maybe even further. Each one is a crucial piece of the puzzle for the clinical team.
All right, let's talk lymph nodes. For pretty much all head and neck cancers, the status of the lymph nodes is the single biggest predictor of what's going to happen.
And you guessed it, salivary gland tumors are no different.
Now, when that neck dissection comes in, it's not just a random bag of nodes. No, it's a map. The nodes are organized by specific levels, as you can see, from level I all the way down to level 7. Surgeons are great about submitting these in different containers, and knowing this map is key, because where the positive nodes are and how many there are directly impacts everything that comes next.
Okay, now for a concept that has completely changed the game for staging: extranodal extension, or ENE. Get this, this isn't just about finding cancer inside a lymph node. This is about cancer that has broken out. It's punched through the wall of the lymph node and is now invading the tissue around it. Finding ENE is a massive deal. It's a sign of really aggressive disease, and it automatically kicks the cancer up to a higher stage.
Which, of course, brings us to the million-dollar question that every single trainee has to know the answer to. How, specifically, does finding NH change the PN category you put in your report?
Let's just break this down because it's so important. Just look at PN1 versus PN2A. The tumor is the same size, same location. The only difference is ENE. A single small node that's ENE negative, that's PN1. But the moment you find ENE in that exact same node, boom, it's immediately PN2A. And from there, if you find ENE in bigger nodes or in multiple nodes, you rocket up to PN3B. I'm not kidding. Identifying and reporting ENE is one of the most critical things you will do at the microscope.
So, let's take a step back. We've collected all our clues: the gross findings, the histology, the grade, the margins, the invasion, the lymph nodes. We have everything. The final step is to put it all together into that clean, standardized report that the clinicians are waiting for to make some really big decisions.
And this is the final product, the synoptic report. The protocol is super specific about this. It's not a story, it's not a long paragraph, it's simple. Data element, response. Why? Because a surgeon who's got a million things going on needs to find the PT stage or the ENE status in about 2 seconds. They can't be digging through a wall of text. This format, it's all about clarity. It prevents mistakes and makes communication seamless.
So as we finish up here, I just want you to think about this for a second. Every time you sit down and carefully fill out one of these protocols, you're not just closing out another case. You are contributing a perfect little piece of data to this huge, structured library of knowledge. And that standardized data we're all creating today, that's what makes the big research studies and the clinical trials of tomorrow even possible. It leads to better staging, smarter treatments, and at the end of the day, better outcomes for our patients. What you do, line by line, really, really matters.